Hello, everyone, and welcome to our continuing education event organized by the team of registered dietitians at Dairy Farmers of Canada. Today's webinar is entitled Diet, Cardiovascular Disease and Mortality, State of the Evidence, with researcher Dr. Andrew MENTE. Pour les personnes qui parlent français, notez que la présentation est offerte en traduction simultanée. Si vous souhaitez cependant l'écouter dans la version originale, veuillez simplement cliquer sur la langue anglaise en haut de la page. My name is Isabel Niderer, and I'm the Director of Nutrition and Research at Dairy Farmers of Canada and your moderator for today. We have more than 2,500 registrations for this event from across the country today who share a common interest in nutrition and health, so welcome everyone. The next 60 minutes will include a 45-minute presentation by Dr. MENTE, followed by a 15-minute question period. Throughout the presentation, though, you can submit questions using the chat box on your screen, and we will try to address as many questions as possible during the question period. Before leaving the webinar, if you're interested, you can download the presentation by simply clicking on the link on your screen. I'm now pleased to introduce Dr. Andrew MENTE. Dr. MENTE received his doctoral degree in epidemiology from the University of Toronto. He then completed postdoctoral training in cardiovascular epidemiology at McMaster University and is currently an associate professor at the Population Health Research Institute at McMaster University. Dr. MENTE and his team conducted the largest ever epidemiologic study of the impact of sodium intake on blood pressure, cardiovascular disease risk, and mortality in a prospective urban-rural epidemiology study known as the PURE study. Recently, Dr. MENTE has co-led an investigation on the role of dietary fats, carbohydrates, and dairy foods in cardiovascular disease in the PURE cohort. He also has conducted numerous large systematic reviews of diet, including investigating saturated fat in cardiovascular disease. And he is currently researching the impact of individual foods on cardiovascular markers and cardiovascular disease events. Dr. MENTE, we are delighted to have you with us today. The floor is yours.
Thank you very much, Isabel. I'm delighted to be here, and thank you for inviting me. It's a pleasure to present some of the work that we've conducted on diet, cardiovascular disease, and mortality, and how the PURE study helps to inform dietary recommendations for populations for cardiovascular prevention. Now, the PURE study is funded by over 70 different funding sources from countries around the world, including in Canada, an unrestricted grant from the Dairy Farmers of Canada and the National Dairy Council in the U.S. The external funders and sponsors had no role in the design and conduct of the study, in the collection, analysis, and interpretation of the data, or in the presentation, review, or approval of the manuscript, or in the decision to submit manuscripts for publication. Now, current dietary recommendations for cardiovascular disease prevention in populations have long stemmed from the diet-heart hypothesis, which really goes back to work done by Ansel Keys back in the 1950s and is the conventional wisdom that drives dietary policy to this very day. And according to the hypothesis, it states that fat intake raises blood cholesterol levels, and higher blood cholesterol increases coronary heart disease in the population. Therefore, if we reduce fat intake in the population, we'll also reduce coronary heart disease as well. Now, since that time, the hypothesis has been slightly revised, and the focus shifted from total fat to saturated fat, and from total serum cholesterol to LDL cholesterol. But the basic framework of the hypothesis remains the same to this very day for over 60 years. Now, of course, this hypothesis assumes that fats affect only LDL cholesterol and have no other effects on any other biological systems in the body. But as it turns out, it doesn't quite work that way. Natural sources of saturated fat, like meat and dairy, for instance, also contain a variety of other nutrients that the body needs, like essential amino acids or protein, monounsaturated fats, B vitamins, including B12, which is predominantly found in almost exclusively in animal products, zinc and other important minerals, magnesium, retinol, selenium, calcium, and vitamin D as well. And these are, of course, important nutrients that our body needs. So just on this information alone, it really does not seem to make much sense to focus on saturated fat's effect on LDL and to extrapolate net clinical impact based on that relationship, as we'll show in the next few slides. And importantly, restriction may result in inadequate intake of key nutrients in certain populations where there is nutrient inadequacy. Now, according to the dietary guidelines by various health organizations, generally it's high carbohydrate diets that are recommended. For instance, the WHO recommends 55 to 75% of energy from carbs, only 15 to 30% of energy from total fat, so less than 30% from total fat, and less than 10% from saturated fat. And according to some organizations, even less than that, less than 7% of energy, according to AHA and NSEP, coming from saturated fat. So this is a very low saturated fat diet, and it basically amounts to following a vegetarian diet, which is difficult for most people to consume or sustain in the long term, certainly. It's also important to note that the average saturated fat intake in the population in Western countries like Canada, United States, and Western Europe, for instance, is about 12% of energy in both sexes. So it's only slightly above the 10% recommendation. So it's not like we're consuming 20 or 30% of energy from saturated fat. On the basis of this information, we would say that there's no saturated fat emergency. It's only slightly above the current recommendation, about 12% of energy. And that's an important number to keep in mind as I present some of the data. So that brings us to the first of our studies, this one published in Lancet Diabetes Endocrinology, where we looked at the relationship between dietary nutrients with blood lipids and blood pressure in 18 countries around the world. And this is a cross-sectional analysis. So we looked at data at one point in time at study entry into participation in the study. And I'll tell you more about the PURE study now in the next few slides. So the PURE study, in this analysis, we focus on 135,000 people recruited from 667 communities in 18 first wave or first phase countries from 5 continents around the world. So PURE covers all of the continents of the world except for Australia and Antarctica. So by covering a broad diversity of the global population, we're able to characterize strengths of relationship between diet and health outcomes, but also shapes of relationships. So not just whether a dietary exposure is related to health outcomes, but also the shape of that relationship from very low levels to very high levels, because we have diversity of diet and we also have diversity of health outcomes. And that's an important advantage that's never been characterized in any previous study in the past. So PURE, as I mentioned, covers multiple world regions and is the only prospective study to do so. And the regions covered include South Asia, China, Southeast Asia, Africa, North America and Europe, Middle East, and South America. In this analysis, I mentioned 135,000 people. And the participants were selected using an unbiased selection from the general population of people living in communities. So these are generally healthy people living in communities in each country around the world, and are aged 35 to 70 years without cardiovascular disease at baseline. We use country-specific validated food frequency questionnaires to assess diet. So each questionnaire was developed and validated specifically for each country around the world. And we measured demographics, other lifestyle factors, health history, and study center. In this analysis, we had blood pressure data on 125,000 people, blood lipids on 104,000, and we also had ApoB and ApoA measures in 18,000 people. And I'll tell you more about those measures in a moment. And we use standard statistical methods to analyze the data while also accounting for community center clustering. So this slide shows the relationship of saturated fat versus the blood lipids. So at the top, you see with higher saturated fat intake ranging from, in the lowest 20% of participants, from 4% of energy all the way up to just more than 11% of energy in the top 20 percentile of the population. We see a triple increase in saturated fat from low levels to high levels, and correspondingly, we see an average increase in average LDL cholesterol from approximately 2.8 to 3.2 millimoles per liter from the lowest to the highest group. So higher LDL with higher saturated fat, but it's a modest association considering that saturated fat difference is triple from the lowest to the highest group. So it's a modest association, in fact. But now we also see that there's also an increase in HDL with higher saturated fat, the so-called good cholesterol. So when we look at the ratio of total cholesterol to HDL, we see, in fact, it's an inverse association. So higher saturated fat is related to lower total cholesterol to HDL ratio. Now, the reason why that's important is because we know from epidemiological studies that total cholesterol to HDL ratio is a stronger predictor of cardiovascular events than LDL cholesterol alone. So on the basis of this information, you get conflicting advice on what to recommend for saturated fat. If you focus on LDL, you would tell people to eat less saturated fat. But if you focus on total cholesterol to HDL, you would tell people to eat more saturated fat, at least up to about 12% of energy. So what marker do we focus on? Well, just to complete this point here are two other markers, triglycerides on the left and ApoB to ApoA ratio on the right. We again see with higher saturated fat, we see lower triglycerides and lower ApoB to ApoA ratio. This also suggests a favorable effect of saturated fat on health, since these are strong lipid predictors of future cardiovascular events, and saturated fat appears to be associated with lower levels, which suggests a favorable effect, which would be beneficial. So what do we recommend given these different relationships between saturated fat and blood lipids? Again, if we focus on LDL, we get one message. If we focus on other markers, we get another message. So the point is we need studies with clinical events. We have to follow people up over time and look at heart attacks, stroke, and mortality to make dietary recommendations, because the blood lipids provide conflicting messages. Also important to point out that these results that I just showed here with the blood lipids are exactly what you would expect for saturated fat versus blood lipids based on what we know from other studies and from randomized trials. This is important because it tells us that the dietary assessment that we've done in PURE is accurate. If it was poor, then we wouldn't expect to see these relationships in the expected direction between saturated fat and the blood lipids. So from this study, reducing saturated fat has an adverse effect on the blood lipids. Focusing on a single lipid marker like LDL does not capture the net clinical impact of fat on cardiovascular disease, and we need studies with clinical events. Now, what do the data show on saturated fat versus coronary heart disease outcomes? After all, outcomes are really the most important thing. Well, here's a meta-analysis conducted by Siri Torino in 2010, and you see that the effect estimates of the various studies conducted all show that the results are not significant. You can see the summary estimate crosses 1.0, which suggests that it's statistically neutral. So there's no association between saturated fat and coronary heart disease when we pool the data collectively across these different prospective cohort studies. We in fact see that directionally and overall, we see that higher saturated fat is associated with a lower risk of stroke that is just borderline non-significant. So if anything, by direction, we see saturated fat trends toward a benefit versus stroke, something not considered by the diet heart hypothesis, which focuses mostly on coronary heart disease. Now, more recently, we did a meta-analysis published in 2015 looking at cohort studies of saturated fat and various health outcomes. total mortality, coronary heart disease, cardiovascular events, ischemic stroke, and type 2 diabetes. And again, you see all the estimates cross 1.0, which suggests, again, that the association is statistically neutral. So again, no relationship of saturated fat and the various outcomes. There are actually clinical trials that replace saturated fat with polyunsaturated fat and looked at coronary heart disease outcomes. And here's a summary of the different meta-analyses that have been published over the last 4 years. And you see the summary relative risk from these studies. And you can see they all cross 1.0. The 95% confidence interval includes 1.0, which means, again, the estimates are statistically neutral. So, again, there's no evidence also from randomized trials that replacing saturated fat with polyunsaturated fat is beneficial. So that brings us to our second paper published in The Lancet in 2017, this one looking at the association of fats and carbohydrates with cardiovascular disease and mortality in the 18 countries in PURE. So the same participants that you saw in the previous data that I showed with the blood lipids. Here, these are people followed up over, at that time, an 8-year period in the PURE cohort. And so the same methods, same participants. Only note here we have for the outcome, this is the prospective data, we have the main outcome of major cardiovascular disease and mortality. We had more than 4,700 major cardiovascular events and more than 5,700 total deaths that were accrued during the follow-up period of about 7.5 years. And we use standard multivariable methods to analyze the data. So this slide shows the risk of mortality by type of fat, saturated, monounsaturated, and polyunsaturated versus risk of mortality. You can see that each type of fat is associated with a significantly lower risk of mortality, both saturated, mono, and polyunsaturated fat, where higher intake is related to lower mortality from lowest to highest quintile, with a risk reduction of approximately 15 to 20%, comparing the highest intake group to the lowest intake group. Note the saturated fat level in the groups, ranging from 3% of energy to 13% of energy in the highest group. So the highest group really in this global sample represents about the average in Western populations, like in Canada, approximately 12 to 13% of energy, whereas the rest of the world, many people fall toward the lower end, all the way down to 3% of energy. So this really shows that if we were to reduce saturated fat down to low levels, we may in fact be increasing risk of mortality based on these collective data from around the world, something not considered in previous studies that focus predominantly on high-income countries. Now, here the slide shows risk of cardiovascular disease on the left and non-cardiovascular disease deaths on the right by type of fat. So you can see each type of fat on the left is associated with a trend toward lower risk of cardiovascular disease death. On the right, we see an even more clear signal where each type of fat is related to a lower risk of non-cardiovascular death, which is statistically significant. So non-cardiovascular death in PURE is predominantly cancer and respiratory mortality. Now, at this stage of the analysis, we don't have enough events to look at individual types of non-cardiovascular deaths to look at them with high degree of statistical precision. So that's something that we can analyze in the second decade of follow-up as the cohort ages and we accrue more events, and we can look at individual types of cancer and respiratory events and other outcomes as well. But for the time being, we see a significant association with lower risk of non-cardiovascular death, and more modestly with lower cardiovascular death. For carbohydrates, we see the opposite. We see higher carbohydrate intake is associated with a higher risk of mortality when carb intake exceeds approximately 60% of energy. So at higher levels of carbs, we see a clear increase in the risk of mortality. Now, it's important to note that the main sources of carbohydrate in many of these countries around the world are not from fruits and vegetables, but rather from refined carbohydrates or refined grains, and some added sugar as well. So it's not due to fruits and vegetables. So the strengths of PURE, just tell you a little bit more about PURE. It's obviously a prospective study. It's large, and it covers 5 continents around the world. So as I mentioned, we cover diversity of diet globally. And therefore, the findings would be globally applicable since we cover a global population. We use standardized and validated methods to measure diet using country-specific food questionnaires, and we extensively adjusted for both dietary and non-dietary covariates. Now, limitations include random measurement error in assessing diet, which affects any epidemiological study looking at diet and cardiovascular disease or any other health outcome. And this may dilute associations toward a lack of an association, rather than magnifying the associations toward it would more likely to dilute associations. Also, high carbohydrate and low fat diets may be a proxy for poverty. To minimize confounding by economics, we took several steps. First, we adjusted for education, income, and wealth index extensively in our models. We also included study center as a random intercept, which accounts for clustering within centers within each country. So what we're doing is we're looking at relationships within countries, or more finely within centers, rather than across countries. And that helps also to minimize confounding by poverty. Also, we conducted subgroup analyses by region. For instance, we subdivided high-fat and low-fat regions and looked at the results within the region, which would also minimize the impact of confounding by poverty. And when we did that, the results were consistent. So it's highly unlikely that the results were due to confounding by poverty. Now, we had fewer events within countries or regions in this first decade of follow-up, but over time, we'll be able to accrue enough events to look at associations within countries and within regions. Now, I mentioned that fruits and vegetables are mostly, we know are beneficial, and other studies have shown are beneficial, and we found similar results in that regard. So we looked at fruit, vegetables, and legumes and cardiovascular disease death in the same participants in PURE in the paper published in the Lancet. And here you see a summary of the results on the left, looking at fruit, vegetable, and legume intake versus mortality, and on the right versus major cardiovascular disease. And you see on the left, you see higher fruit, vegetable, and legume intake is associated with a lower risk of mortality all the way up to about 3 to 4 servings per day, and then the risk is constant all the way up to 8 servings of fruit, vegetable, and legumes per day above that. So 3 to 4 servings per day appears to be associated with a maximal benefit toward lower risk of mortality. On the right, we see an association with lower risk of major cardiovascular disease, though the effect is more modest. And when you take out cooked vegetables, then the association is stronger. So raw vegetables and fruit and legumes appear to be the most beneficial. So higher carbohydrate diets exceeding about 55% of energy or higher are associated with higher mortality. Fats, including saturated and unsaturated fats, are associated with lower mortality. There's no association between total fat, types of fat, and cardiovascular events. And the current advice to limit total fat to less than 30% of energy and saturated fat to less than 10% are not supported by this global data. So that brings us to our paper published last year where we looked at dairy product consumption and cardiovascular disease and mortality in 21 countries in PURE from 5 continents. Now, the reason here now we have 21 countries instead of 18 is because 3 countries that entered PURE a few years later than the original 18 countries now had a sufficient amount of follow-up to include in this analysis. So we're able to now look at 21 countries around the world. And this slide shows total dairy intake with versus the clinical outcomes, the composite of cardiovascular disease or death, mortality, and major cardiovascular disease. So you can see here at the top, higher dairy intake from comparing people who do not consume dairy compared to people who consume greater than 2 servings per day of dairy. We see an association with a lower risk of composite of death or cardiovascular disease with higher dairy, with maximum benefit among those who consume greater than 2 servings of dairy a day, about a 16% lower risk in those people compared to people who did not consume dairy. We see a similar pattern of results for total mortality and for major cardiovascular disease events, with about a 17 to 22% lower risk among those who consumed more than 2 servings per day compared to people who did not consume dairy. So in short, dairy is associated with about a 15 to 20% lower risk of major cardiovascular events or death if you consume more than 2 servings per day compared to avoiding dairy. And we also looked at other outcomes, non-cardiovascular death, cardiovascular death, myocardial infarction, and stroke, and we see a similar pattern of results where higher dairy is associated with a lower risk of each outcome. Note it's particularly striking for stroke, with about a 34% lower risk in those who consume more than 2 servings per day compared to non-dairy consumers. And it occurs in a graded fashion, with higher amounts being more beneficial. And this is consistent with the meta-analysis that I showed earlier, showing that higher saturated fat was associated with lower risk of stroke. Then what we did then is we subdivided the different types of fat, whole fat dairy versus those who consume whole fat combined with low fat. And what we found on the left, we're looking at whole fat dairy alone, is we see that the signal is more clear among those who consume whole fat dairy. Comparing the lowest consumers to the highest consumers, we see a graded association with a lower risk of composite of cardiovascular disease and mortality, total mortality, and major cardiovascular disease, with higher whole fat dairy intake. Among those who consume whole fat with low fat, again, we see directionally a benefit, an association with benefit, though the association is more modest. So clearly, it appears that the beneficial association of dairy with health outcomes appears to be driven mainly by whole fat dairy. Then we looked at different type of dairy foods. Yogurt and milk were each associated with lower risk of each outcome, the composite, mortality, and major cardiovascular disease. We saw similar pattern of results for cheese, but it was not statistically significant. Butter, not shown here, was statistically neutral, neither an increase nor a decrease in risk, though intake of butter was very low in the population, which it really made up less than 2% of total dairy intake. So it was a small amount of butter consumed by participants. Then what we did to minimize the impact of confounding by poverty, we further stratified the population looking at countries that consume low amounts of dairy versus countries that consume high amounts of dairy. And we looked at the associations within each region. And what we found was that the association of higher dairy intake with lower risk of health outcomes was consistent across regions, both in the low intake region and the high dairy intake region, which tells us that regardless of the region of the world where you get a lot of poorer countries here in the low intake region compared to the high intake region, even within these regions we see a similar pattern. So it's much less likely that our findings are impacted by factors like poverty. So higher dairy intake, mainly from whole fat dairy, is associated with a lower risk of mortality and cardiovascular disease, particularly a lower risk of stroke. Now, I'll tell you some of the current work that we're focusing on. We are currently doing ongoing work on other dietary exposures, namely foods like red meat, poultry, fish, eggs, and nuts. These papers are in advanced development, and some have already been submitted to journals. Others will be submitted very shortly, because as we have very advanced drafts. And we're also developing a global healthy diet score, which I'll also tell you about now, and is very important work as part of the PURE study. Now, our central hypothesis is that non-communicable diseases globally may be caused by a diet comprised of low amounts of several natural or minimally processed foods, including fruits, vegetables, legumes, nuts, and fish, but also low amounts of dairy, especially whole-fat dairy, and unprocessed meats. So much of what we know of diet in populations comes predominantly from high-income countries where there's nutrient abundance and high intakes of many foods, including whole-fat dairy and unprocessed meats. But there's very little we know in other parts of the world where there's undernutrition, where they consume low amounts of these foods. So it's important to get a global perspective. So we looked at data from 6 large international studies, 244,000 people in 80 countries around the world. So here you see the 6 studies. 3 of the studies, Pure, On Target, Transcend, and Origin, are prospective studies, while InterHeart and InterStroke are 2 international case control studies of MI and stroke. Now, the 4 prospective studies, you could see here the large number of events, large number of individuals participating in a large number of cardiovascular events and deaths. And we see that 3 of the studies are global studies, while On Target, Transcend, and Origin cover 40 countries around the world. So we have big numbers with large number of participants and large number of clinical events, and we have diversity of exposure and clinical outcomes because we look at global populations covering from low intake to high intake around the world. And so we capture broad patterns of diet globally with big numbers. And so what we did first is we developed a healthy diet score in Pure, 147,000 people in 21 countries, based on intake of foods associated with a lower risk of mortality. And what we found was that there were several foods that were associated with lower risk of mortality: vegetables, fruit, and legumes, which I showed you in a slide earlier. Nuts and fish are also associated with lower risk. Dairy, which was the previous slides that I showed you in our paper published in the Lancet, but also unprocessed red meat and white meat as well, or poultry. So unprocessed red meat and poultry also associated with lower risk of mortality. And so what we did is we created a scoring scheme where each food receives a score of 0 or 1 based on if intake is above or below the average in the population. So if people consume above the average, they get a score of 1 for that food. If they're below the average, they get a score of 0. And then you simply take a sum of all of those different food scores with a maximum score of 8 and a minimum score of 0, because there are 8 foods in total, so the highest score you can get is 8, and 8 represents the highest healthy diet score, whereas the score of 0 would represent the least healthy diet score. And so this just shows you what a low and high healthy diet score looks like. So an unhealthy diet score, that is people in the lowest 20% of the Pure diet score, are people who consume on average of only 1 serving of fruit and vegetables a day, 0.4 servings of nuts and legumes, 0.3 servings of dairy, and 0.2 servings of red meat and fish. Note that this is a very high carbohydrate diet. Almost 70% of energy comes from carbohydrates. As I mentioned earlier, it's mainly refined carbohydrates, not fruits and vegetables. And only 18% of energy from fats, so less than 20% of energy from fat. These are people consuming a high carbohydrate, low fat diet. By contrast, there's the people with the highest Pure healthy diet score, those in the highest 20%. We see that they consume about 4.5 servings of fruits and vegetables, 1.5 servings of nuts and legumes, 2 servings of dairy, about 1 serving of red meat, and 0.3 servings of fish per day, or about fish maybe about twice a week approximately. So this is a diet that is much more balanced. You see that there's about a 54% intake of carbs, close to 30% of energy from fats, 18% from protein. This would translate into a diet that includes a variety of different foods, as shown here, all in moderate amounts. So this is not an extreme diet. It is not a keto diet or a carnivore diet. It is a diet that includes a variety of foods, all in moderate amounts. In other words, a regular diet. So first we looked at the risk of mortality by level of the healthy diet score. So all we did here is we simply divided the 147,000 people into healthy diet score fifths, from the lowest 20%, the next 20%, all the way up to the highest 20%. So the highest quality diet would be the people here with people with a score of 6 or greater. And here you see the number of people in each group and the number of deaths in each group. And you see the number of the proportion of people who died during the follow-up. You could see just by looking at the number of deaths that the proportion of people who died goes down with the higher quality diet score. When we adjust for age and sex, we see a graded association all the way up to the highest fifth of the diet score. The hazard ratio here of 0.56 means that there's about a 46% lower risk of mortality among those with the highest diet score compared to those with the lowest diet score. So that's a strong association. When we extensively adjust for known confounders and add them to the model, the effect is halved approximately. We get about a 25% lower risk, those in the highest compared to the lowest diet quality score. Then we took the same data here and we plot it on the left. We show it pictorially, comparing the lowest to the highest score. You see a graded association again with lower risk, but a 25% lower risk in those with the highest score compared to those with the lowest score. On the right, we look at major cardiovascular disease. Again, we see a graded association with lower risk, though the association is more modest, with about close to 10% lower risk in those in the highest compared to the lowest diet score. Then what we did is we took the same score and we applied it to the three other prospective studies. This is data from OnTarget, Transcend, and Origin. This is high-risk population of participants, those at high risk for cardiovascular disease or with existing vascular disease, 43,000 people around the world. And you see on the left, we see a similar pattern of results, higher diet score associated with a lower risk of mortality with a hazard ratio of 0.76, very similar to what we see in PURE. On the right, again, we see a similar pattern where higher diet score is related to lower risk of major cardiovascular disease, with the association more modest than what we see for total mortality. So essentially a similar pattern of results as what we observed for PURE. This in a high-risk population of vascular patients. Then we took the same score and we applied it in yet another study, this one the international intra-heart study, looking at risk of myocardial infarction. And we see that, again, the higher diet score is associated with a lower risk of MI with a hazard ratio of 0.60 in the highest group. Then we extensively adjust for confounders. We see that the effect estimate is halved, about approximately a 22% lower risk among those in the highest diet score compared to the lowest diet score. So a lower risk of MI. And in the intra-stroke study looking at stroke, we see a similar pattern of results where, again, the higher diet score is associated with a lower risk of stroke. Similar association, about a 25% lower risk of stroke among those in the highest diet score compared to the lowest diet score. So when you take the same score and you apply it to different study designs and different cohorts and different populations around the world, you see a similar pattern of results, which shows remarkable robustness of the results. So to conclude, the PURE Healthy Diet Score, comprised of higher intake of fruits, vegetables, nuts, legumes, and fish, but also includes dairy and meats, is associated with a lower risk of mortality and cardiovascular disease globally. There's consistency across 6 international studies using different designs involving 244,000 people from 80 countries. There's consistency of the results in those with and without prior vascular disease. And it's important to point out that some elements of the PURE Healthy Diet Score, such as dairy and meats, differs from current advice derived mainly from studies performed in high-income countries. So this is, for the first time, we include dairy and meats as protective foods in a global population, and we see that the score is very consistent and robust in predicting lower risk of mortality and cardiovascular disease. So from this take-home message, we recommend people eat more fruits, vegetables, nuts, legumes, but also eat dairy, mainly whole-fat dairy, and unprocessed meats as well. Eat less refined carbs and refined grains and sugar, and less sweetened drinks. And there's pretty good data from many different studies that industrial trans fats are related to harm. So from that, I think I'll conclude by showing a photo of the various investigators from the Pure Investigators meeting in New Delhi, India in November of 2017. So thank you very much for your attention and for inviting me.
Thank you very much, Dr. Mente. We now have time for a 15-minute question period. And here's the first question coming up.
Sure.
Just a second. Which dairy products were taken into consideration in the Pure study?
Yes. So we included yogurt and cheeses, various cheeses, yogurt drinks as well, cheeses, milk, and cream, and those were the main sources there.
Okay. So the next question. Just a second. How is it possible that the average of saturated fat intake is 12%, considering the increase in the consumption of fast food?
This is according to survey studies that have been conducted. The average saturated fat is approximately 12% in Western countries, including the U.S. So a lot of the fast food, as you know, is not the saturated fat itself. Of course, saturated fat is part of it, but it also includes other different sources of energy, mainly refined carbohydrates and sugar. So it's not mainly saturated fat, despite what is thought. In fact, saturated fat over time has gone down over the last over the last 2 or 3 decades, replaced mainly by carbohydrates in the diet. So really, in essence, is pretty much backfired based on data from Pure and other studies as well.
Okay, thank you. The next question is, So do you think that these population-level results can be applied to individuals with dyslipidemia? In Canada, the source of saturated fat may be very different from other countries as well. So does the type of saturated fat matter?
Yes. So first of all, the first question, we found that the results were consistent in people with existing vascular disease, and presumably many of these people, or most of them, have issues with lipids, and yet the results were consistent even in that population as well. Again, consuming up to 12% of energy, we see, and with the Pure diet score as well, up to the highest quintile of the diet score, we see benefit. But for saturated fat, up to about 12 or 13% of energy. So our data are not covering, say, 15 or 20% of energy from saturated fat. So that's not what we're saying. We're not saying consume an unlimited amount of saturated fat. But being at 12% or 13% of energy appears to be optimal compared to people who are at lower levels who are actually at increased risk. And this is regardless of people having cardiovascular disease or not. So it appears that is the optimal amount. And sorry, what was the second question?
The second question, we have to go back just a second.
Sorry.
Was related to the different sources of saturated fat in the diet.
Yes.
That they must be different depending on the country, and so, yeah.
Yes, an important question. So we looked at it, first of all, we looked at the individual different types of dairy foods. So both yogurt and milk were protective, mainly whole-fat milk and whole-fat yogurt were the most protective. Whole-fat cheese generally has higher amounts of whole fat. That was also protective, though the association was not statistically significant. But it trended the same pattern, higher amounts trended with lower risk. And so there we look at different sources of saturated fat. We're also now looking at a separate paper looking at red meat. Red meat generally we find, as long as it's unprocessed meat, is associated with a lower risk of mortality. Also, what we can do is we look at individual types of dietary fatty acids, so specific types of saturated fat and types of mono and polyunsaturated fat. And that's an ongoing analysis that we're currently looking at. And then ideally to also get blood fatty acids as well. So we have a small amount of funds to look at that, though we need to raise more funds in order to look at blood fatty acids versus events, and that would be very, very informative if we can do that.
Okay, thank you. Now, we have a question that is quite general. It says, could you please address the criticisms about the PURE study, but it doesn't specify which criticism.
Yes, it's a good question. There's two main criticisms. One is the measurement of diet. Now, it's important to note the way we measure diet is the way other studies measure diet. We use dietary questionnaires, and that's the way diet is measured in large epidemiological studies. So whatever criticism is levied at PURE for using dietary questionnaires should also be applied to other cohort studies that use dietary questionnaires because we use the same approach. We developed and validated the questionnaire specifically for each country to reflect the food supply of each country, and more finely, in urban and rural areas of each country. So it was a huge amount of work and took many years to even develop and validate the questionnaires that we applied. We also see similar pattern of results for relating our measures to blood lipids that you would expect with randomized trials that have been conducted. If the dietary measure was poor, then we wouldn't see relationships with blood lipids that we see in the expected direction and magnitude. So that further reassures us of the accuracy of our dietary assessment. The other criticism is that a dietary exposure like dairy, for example, could be a marker of poverty, whereby the lowest dairy consumers are also people that are poor. So it's not really dairy, but rather poverty that is driving the association between dairy and cardiovascular events and making dairy look protective when it's really not protective, it's really poverty. But there's a number of measures that you can that you can do to address that criticism. Number one, we extensively adjusted for socioeconomic indicators in all of our regression models. First, education is the strongest risk predictor of cardiovascular events and death in the PURE study. So when we adjust for education, the results are robust, and there's no change in the association. We also use other measures of socioeconomic status, like wealth index and income. When we adjust for those measures, again, the results are consistent. Then what we do, in combination with all this, we also include study center as a random effect in our multivariable models. Now, when you do that, what it does is it looks at associations within the study centers rather than across the study centers. And there are study centers within each country. So that, in effect, makes us look at within countries or more finely within centers of each country rather than across centers. So we're not comparing, say, for example, India to Canada. What we're doing is we're looking at within India or within centers in India and within centers in Canada. And by doing that, that also helps to minimize the impact of confounding by poverty because we're looking at within the population. And the third step is you also can do subgroup analyses where we look at the associations within regions, where we look at within the low dairy intake region and the high dairy intake region. As I showed in one of the slides, the associations were similar. So many of the countries where dairy intake is lower, they're in the low intake region analysis, and we see a similar pattern of results where dairy was still protective even among those poorer countries. So combining these three approaches, you can greatly minimize or eliminate the impact of confounding by poverty. Now, no amount of adjustment is perfect 100% in the absence of a large randomized controlled trial. However, doing what's humanly possible we find that the results are very, very robust and consistent.
Okay, thank you. Next question is, in your study, did you distinguish carbohydrates from whether they're from low-processed fresh foods or from processed foods?
Yes, we have an advanced draft of a paper that we're going to submit to a journal soon. That is led by David Jenkins. Obviously, the pure investigators are a key part of that paper, and David Jenkins has taken the lead on that paper, and he has helped to. He's obviously the global leader in glycemic index work done going back decades, and he has helped us to classify each of the food items based on whether whole grain or refined grain or other classification of each type of food. And so we have a paper that is about to be submitted, and it's mainly the refined carbohydrates that are found to be harmful, whereas whole grains are generally neutral.
Okay, thank you. Next question is, we would like to have your thoughts on specifically on patients with cholesterol. I believe high cholesterol level. Would you recommend a low cholesterol diet?
Well, based on our data, first of all, the dietary cholesterol has been shown in many studies has little impact on blood cholesterol levels. So presumably the question is referring to saturated fat in the diet. And so saturated fat, we find, both in our data and other studies, has a very modest impact on LDL. And the whole basis of reducing saturated fat to low levels among people with high cholesterol levels in the blood is because of LDL. But we see that there's only a modest association. And in fact, you see favorable effects on HDL and triglycerides and total cholesterol to HDL ratio. And we also see favorable effects on ApoB to ApoA, which is a measure of the small, dense LDL particle that is more atherogenic than LDL cholesterol alone. So the fact that higher saturated fat trends toward lower ApoB to ApoA and toward lower triglycerides and total cholesterol to HDL ratio suggests that focusing on the blood lipids and focusing on LDL may misinform the diet for people with blood lipid problems, and in fact may even be beneficial up to about 12 or 13% of energy anyway, which is the range covered by our data. Above that, then the evidence is much more murky, and we're not sure. But up to about the population average in Western countries, that probably is in fact an optimal amount to consume based on our global data. So I would say regardless of what your blood lipid levels are, there's no need to restrict saturated fat down to low levels. And you can eat foods like whole fat dairy and unprocessed meats in moderate amounts.
Okay. Now, can you comment on how the pure diet score compares to the Mediterranean diet score? They both seem very similar, with the exception maybe of red meat.
Yes, great question. We compared the Mediterranean diet head-to-head with the pure diet. So in the same participants, we scored them both on the pure diet score and on the Mediterranean diet score. And we found that the estimates were very similar between the two, though the pure score was slightly better. Just slightly better, but it was not statistically significant. So adding meat and dairy to the score, directionally anyway, appeared to be better than not including dairy and meat in the score, though it wasn't statistically significant. So Mediterranean diet did similar to pure, but our diet score was significantly better than DASH and considerably better than a planetary diet score that we calculated as well.
Interesting. The dietary pattern diet that you're referring to is the Eat Lancet diet, right?
Yes. Similar to that, yes.
Okay. Do you think that in light of your results, it would be relevant to concentrate research on the degree of processing of foods rather than on nutrients as such?
Yes, I would say that focusing on processing would be much more informative than nutrients. Nutrients, we see both in our data and even trials like the Women's Health Initiative trial that you don't really get much of an effect on various health outcomes. Whereas focusing on functional foods, you get much more stronger associations between intake and outcomes. And so, therefore, focusing on the degree of processing of individual foods, I think, would be more informative. So, minimally processed or unprocessed would be ideal. You certainly want to minimize ultra-processed foods, highly packaged ultra-processed foods.
Okay, thank you.
Welcome.
We do have other questions. In Canada and in the U.S., both high-income countries, dairy products are consistently below recommendations of 2 to 3 servings per day, based on the previous food guide. What are your thoughts about that? Would you recommend that people increase their? I suppose the question is, since the intake of dairy is below what is the level that is optimal in the PURE study, would you recommend people increase their intake?
Yes, absolutely. I would say consuming certainly up to 3 servings of dairy a day is certainly appears to be optimal. And so if you're consuming lower amounts, it according to our data and other cohort studies as well, up to about 3 servings per day would probably be beneficial. Though, again, this is based on observational studies, and there are no randomized trials. So just going by that, eating higher amounts, up to 3 servings a day, whole-fat dairy, I would say is favorable. I do not support the current approach of lumping dairy together with plant-based proteins because they are not nutritionally equivalent. There's much higher quality protein and nutrition in dairy than in plant-based protein. And lumping them together into one group as if they are the same, I think is inappropriate in my view, in interpretation of the data. So, and then technically, one can meet the Canada Food Guide recommendations if one avoided dairy entirely, and you would still be meeting the recommendation of the Canada Food Guide. Mm-hmm. So I don't think it's appropriate to lump them together because there's really no substitute for dairy in getting a higher quality diet. Okay.
Now, specifically with regards to cheese, the cheeses that were included in your study, were they high in fat? Were they regular fat or lower fat? Can you comment on that?
They were mostly higher in fat. In many of the countries included around the world, it was mainly higher fat cheeses. Some of the amount of cheese in Canada and Sweden may have included some lower fat cheese, but mostly collectively, looking at the data, 147,000 people, the vast majority of those people was high fat cheese.
Okay. Okay. Next question is, what advice would you suggest for vegetarians or those with a dairy allergy? Should they seek out coconut and palm oil? Is the benefit similar to saturated fat from a dairy and meat perspective?
Okay. Well, people who are lactose intolerant, they can still have lactose-free milk available, or they can have smaller amounts of dairy mixed together with other foods. So you could still eat dairy, but with other foods. I would say coconut oil, the jury is still out. We don't know. Certainly there's no evidence to suggest harm despite all the hysteria about coconut oil specifically. And palm oil as well, I don't think is really a substitute for dairy. So I would say if you absolutely cannot eat any type of dairy, you certainly want to get some animal source protein into your diet, higher quality protein than what you would get strictly from plants. And at least getting some animal-based protein would be favorable.
Okay, thank you. And now I believe this is the last question now. Can you comment on the recommendation in the new Canada's Food Guide to reduce saturated fat and replace saturated fat with unsaturated fat? Your data seems to does not support that recommendation. Can you comment on that?
Yes, based on the amount of saturated fat we consume now in societies compared to we don't eat what Finland ate 40 years ago, where they had 20 or 30% of energy from saturated fat. What we eat now, about 12, 13% of energy, there's no basis, according to the data, to reduce saturated fat down to low levels and replacing it with polyunsaturated fat to low levels, based on the data, both from randomized trials and also from cohort studies like PURE. So I would say that 12 or 13% of energy from saturated fat is fine, and if not optimal. And rather than focusing on saturated fat, in fact, we should be emphasizing protective foods, including whole fat dairy, as a way to minimize chronic disease. I think that would be the way forward.
Okay, thank you. Well, that's all the time we have today. I know there's lots of other questions that were not answered, but unfortunately we have to end now. Before you leave, we would greatly appreciate your feedback, so please take a few minutes to complete the survey. You may also print a certificate of attendance for your professional records. Now, on behalf of Dairy Farmers of Canada, thank you very much, Dr. Mente, for your participation, and thank you all for joining us today.
Oh, my pleasure. Thank you for having me.